about vaccines, primary care, and public health after COVID. What's next? I first want to say a few words about the International Vaccine Access Center. My name is William Moss, and I'm the Executive Director of the International Vaccine Access Center. And we at IVAC aim to accelerate equitable and sustainable access to vaccines in low and middle income countries by generating, synthesizing, and using evidence to inform decision-making and action. We're based in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. And we work across a wide number of domains. We provide country support in many countries throughout the world, but particularly in Nigeria and India. We do this in India through our Maternal and Child Health India project that was started about a year ago. We do this through our rotavirus work, our HPV work. We also do a lot of generating and synthesizing evidence on disease epidemiology, particularly for pneumococcal disease under the PERT study and the Serenade project. We do a lot of work in the economics and financing of vaccines through the Decade of Vaccine Economics work, and more recently, the Vaccine Economics Research for Sustainability and Equity, the VERSE project. And we also work on vaccine coverage and equity. We have a data visualization on vaccine coverage and equity called ViewHub, and are working on equity through our USAID funded Momentum project and our Bill and Melinda Gates funded project on strengthening immunization systems through serosurveillance. Next slide. We, as many organizations, have pivoted somewhat in response to the COVID-19 pandemic, and a lot of us at IVAC are working in these areas. We provide resources for health workers. I'll say a little bit more about that. Virtual trainings and webinars such as this one, response and relief activities in India. We have a vaccine tracker and dashboard, the ViewHub that I mentioned. We're doing social media research on vaccine hesitancy and economic analyses, and much more. Just to highlight some of our training initiatives, we have a vaccine training compendium, a COVID-19 vaccine resource library, and just recently launched a vaccination chat box called Vera. And people can find out more information about all of these on our IVAC website. And then lastly, we've been very engaged through projects led by Lois Priver-Dumb in Baltimore, particularly the Value Baltimore project, but we're also working very closely with Baltimore City on the immunization initiative, influenza immunization initiative, and on providing guidance on COVID-19 vaccines for older adults. So it's now my great pleasure to introduce Dr. Tom Frieden. I'm sure all of you know of him. He's currently president and CEO of Resolve to Save Lives, which is an initiative to prevent cardiovascular disease and epidemics. And he is one of the most prominent voices in public health, both domestically and globally. Dr. Frieden received his medical degree from the Columbia University College of Physicians and Surgeons actually in I won't say the year, but it was 2 years after I graduated from PNS. And then he went on to obtain his MPH at the Columbia University's Mailman School of Public Health. Did his internal medicine residency at Columbia, where I also trained, and his infectious disease fellowship at Yale. Dr. Frieden then went on to be an EIS officer at the CDC, where he was posted to New York City. And from 1992 to 1996, he served as director of the Bureau of Tuberculosis Control in the Department of Health and Mental Hygiene in New York City. And I don't expect Tom to remember this, but he was actually my MPH advisor when I was a pediatrician working at Harlem on tuberculosis in children. After serving in the New York City, in the Bureau of TB Control, Tom later went on and became he went on to India to work work on tuberculosis control in India for several years as a medical officer with the World Health Organization, seconded from the CDC. And then he became commissioner of the New York City Department of Health and Mental Hygiene from 2002 to 2009. And he instigated a number of really important public health measures, and including banning smoking in public in city restaurants and the serving of trans fat. From New York City, Tom went to Atlanta and served as the director of the U.S. Centers for Disease Control and Prevention from 2009 to 2017 under the Obama administration, and played key role in the Ebola outbreak of 2014, among many other great public health contributions. And as I said, Tom now is the president and CEO of Resolve to Save Lives. So, Dr. Frieden, it's our great pleasure at the International Vaccine Access Center to have you with us today, and thank you for joining us.
Thanks, William. And I was wondering if it was the same William Moss, because I do remember the project that we did together on tuberculosis. But I'll be talking today about vaccines, primary care, and public health. After COVID, what's next? Next slide, please. What's next is the next slide, please. The United States and the world failed the COVID test. Really, there are three things that we must get right going forward: public health, primary care, and individual and community resilience. Next, please. The first lesson from the COVID pandemic is that we need a public health renaissance. In this country, the United States, we need alignment among public health entities at the local, city, state, and national level. And globally, we also need to see that alignment between the subnational, national, and global levels. We also need much better alignment between public health leaders and political leaders. We need to rebuild trust in public health and in public health institutions. We need to ensure that we have real-time data to make real-time decisions, because in a pandemic, time is lives. We need more staff who are expert and have extensive, practical, frontline experience. And we need sustained investment, not only of financial capital, money, to strengthen global health, but also political capital. Next slide, please. Our global health architecture needs to get dramatically better. There are funding gaps on the order of $5 to $10 billion a year that will be needed for at least 10 years. That funding is important, but insufficient. We also need more and better trained specialized staff who are able to transform those financial resources into functional capabilities. We need operational organizations with more managerial capacity, stronger organizations, including regional and national CDCs, and we need better governance, better ways to resist inappropriate political interference and secure sustained preparedness funding. And we need better mechanisms. The World Health Organization is essential, but it needs support from partners, and new global capacities are needed. And we need to address the scope of public health challenges, not just medical and healthcare, but more broadly, with multi-sectoral approaches to address economic needs, educational needs, social needs. All of this is essential, not just for pandemic response, but for health improvement more generally. Next slide, please. In a public health emergency, public health must guide us forward. Support for public health means funding, using publicly available information, using public health messaging, having meaningful surveillance, including trends in excess mortality, smarter, more nuanced starting and reopening based on risk, looking at the differences between schools versus workplaces, outdoors versus indoors, different group sizes, and the importance in many settings of continued mask use. The box it in of testing, isolation, contact tracing, quarantine to prevent cases from becoming clusters and clusters from becoming outbreaks. Global solidarity, because a global pandemic requires a comprehensive and coordinated global response. Next slide, please. COVID preparedness was insufficient. Many well-prepared countries, including the US and the UK, performed poorly. Bad politics trumped good public health. There were failures in planning, in organization, in implementing, and in communicating effectively, accurately, honestly, and in real time. But this wasn't the only problem. Public health programs had important pre-existing conditions, pre-existing weaknesses, including the lack of alignment among federal, state, local agencies, governments, and partners, and antiquated and incomplete systems for informatics, laboratory networks, surveillance, trained staff, and communications. And throughout this past devastating year and a half, it's been so clear that speed matters, that time is lives, but our system was not built to move at the speed needed. Next, please. Keeping the world safe now and in the future means public health systems need to reinvest. We need solutions to strengthen core capacities to prevent, detect, and respond to outbreaks and break the cycle of panic and neglect. We can't afford another multi-trillion-dollar pandemic, but we can and must afford and implement the health security measures needed to prevent the next pandemic. Next. Just last evening, we published in The Lancet an aspirational and accountable goal called 717, that every outbreak that emerges anywhere in the world should be identified within 7 days of emergence, that the outbreak would be reported publicly and the investigation and response begun within 1 day, and that an effective response would then be established within 7 days. We think this approach can galvanize global progress, stopping epidemics. But to succeed, we'll need money, technical expertise, and stronger organizations. Next, please. The next key lesson has to do with primary healthcare, which is the most needed but most neglected aspect of healthcare systems in nearly every country in the world. Public health can improve the efficiency of our health system, and public health and healthcare have to work together to maximize health and save lives. Next, please. Primary care has to be at the center of our health system. Accountable, high-quality primary care is essential to improving health of individuals and populations. Care by integrated multidisciplinary teams allows doctors to manage much larger panels of patients and to use their skills where they're most needed. Care needs to be patient-centered, with clinical encounters at times and places most convenient to patients, and with out-of-pocket costs, both direct and indirect, minimized or eliminated. Strong and reliable primary healthcare systems are essential for infectious disease control. They're central to epidemic detection and response, diagnosis, treatment, vaccination, and they strengthen community resilience against COVID and future health threats. Next, please. We also need to do much better protecting healthcare workers. In much of the world, there's a shortage of physicians, nurses, and other trained health professionals. Healthcare workers need to have safety, including infection control, supportive supervision with ongoing training, regular and competitive pay, socioeconomic, legal, and spiritual support, monitoring, and quality improvement. And in all too many countries, we're seeing violations of the norms of medical neutrality, with healthcare workers subject to insecurity and attack. Next. In the context of COVID, we have to greatly improve infection prevention and control. We have to address the risk of treatment interruption through innovations, including 90 and 180-day prescriptions, medication delivery, telemedicine, strengthening primary care and team-based care, and treatment in the community instead of in hospitals. Next, please. Primary health care is integral to global health security, to building resilient populations, to early detection, protecting health workers, responding, treating, and triaging, maintaining essential services so that important functions, whether it's maternal child health or treatment of infectious diseases such as tuberculosis and HIV, or treatment of high blood pressure and diabetes, is not interrupted in these times. And building trust in health systems. Strong and reliable primary healthcare systems are central to epidemic response. Next, please. Universal healthcare has to be much more than just a slogan. Primary healthcare strengthening is mandatory. We need action and accountability, not just lofty goals. We've had uneven progress, actually quite limited progress, in the more than 4 decades since the 1976 Alma Ata Declaration. Hypertension control is a leading indicator and can drive crucial change because providing effective hypertension treatment both requires and facilitates establishing effective primary healthcare systems. Next. High blood pressure is the leading risk factor for preventable death worldwide. It kills more people than all infectious diseases combined. And starting at 115/75, every 20 millimeter increases or actually doubles vascular mortality ages 35 to 70. Next, please. Most people with hypertension in the world don't have it under control. Only about 1 in 7 people in the world have the world's leading killer adequately treated. Next, please. Of all adult primary healthcare interventions, improvement in hypertension control can save the most lives. Next, please. In order to do that, you need a systematic approach using drug and dose-specific protocols, quality-assured medications and equipment, team-based care, patient-centered services, and systematic monitoring to establish continuous program improvement. Next, please. Going on to the third lesson I'll speak of, the importance of healthier populations, of strengthening individual and population resilience, addressing groups which, because of geography, demographics, politics, or other factors, are alienated from the government or from health systems that reduce, and that itself is a warning of an area where disease can spread widely and will be much more difficult to control. We need to structure environments to support healthy behaviors, to reduce avoidable illness, injury, disability, and death, to address health disparities which are unacceptable, to increase resilience, to reduce risk and harm of the next emergency. Next, please. Improving health means ending the tobacco epidemic, protecting people from unhealthy food, promoting physical activity, reducing pollution of air and water, reducing harmful alcohol use, protecting our children from addiction to tobacco, alcohol, and drugs, and from predatory marketing by junk food companies. Next slide, please. This is the public health impact pyramid, factors that affect health. At the base levels are socioeconomic factors such as anti-poverty programs, education, access to healthcare, eliminating disparities. One level above that means changing the context to make the individual's default decision healthier. That might be food fortification or tobacco taxes. One level above that are long-lasting protective interventions, of which immunization is the paradigmatic example. one and done, or once a year, or once every 5 or 10 years, with huge benefits. One level above that are ongoing care for things like high blood pressure. And above that is health education, one-on-one or small group activities to try to improve healthy behavior. And what you see generally is increased population impact at the lower levels of the pyramid, but a need to act at every level of the pyramid for an optimal program. Next, please. Generally, the lower levels of the pyramid are more controversial. So you can't always work in the areas that are most effective. You have to work at every level and drive for more and more access, more and more health improvement, more basis on confronting the factors, whether it's the tobacco industry or unhealthy water that is spreading disease in a community. Next, please. We have to address needs that go way beyond just the healthcare system. Of course, we have to address healthcare infection prevention and control, but also things like broadband internet, reorientation to primary health care, supporting global health security, supporting health departments at the national, state, local, and global level in every country in the world. Next. Thinking a little more about vaccines, as those in this meeting know, vaccines save more than 2 million lives worldwide every year. Expanded programs reduce the number of people who die from vaccine-preventable disease, saving tens of millions of lives. But despite this progress has stalled in recent years, and more than 1.5 million people currently die every year from vaccine-preventable diseases, most of them under age 5. Next. COVID disrupted routine health services, including immunization programs. Some countries have restored some services, but many haven't recovered fully. Measles initiatives were suspended in nearly 24 countries, affecting 140 million children. And we're going to see large measles outbreaks that could be deadly, especially in Africa. Even before COVID, measles was killing close to 100,000 children a year. That number could double or triple or more unless we take urgent action. Next, please. COVID vaccines are safe and effective. They hold the promise for an eventual end to the pandemic. The rollout has progressed well in the US and some other high-income countries, but it has stalled elsewhere. Vaccine nationalism is ethically unacceptable, but unfortunately politically inevitable. And the need for vaccine will outstrip supply unless there's much more manufacturing. That's why we need to address inequities in vaccine programs, immediately redistributing doses, but also immediately ramping up production. We don't yet know how long immunity will last, how we can accelerate manufacturing, and how to increase trust in vaccines, but we have to address these things urgently. Next. In the US, lower income communities and communities of color have been hardest hit and yet lack vaccine access. We need more strategic vaccine delivery. Community leaders and community networks will be important to strengthen education, to listen to what communities are, to support communities, families, workers, contacts, and patients, to advocate for services and care. Next. Globally, some high-income countries have vaccine far in excess of population needs, while many countries have little to none. Less than 2% of the population of Africa has gotten a single dose. This is unacceptable, and it reflects a global failure to provide vaccine equity for Africa. We must rapidly increase vaccine production and distribution to all countries, regardless of income level. Equitable distribution will lead to maximum impact for fairness, to reduce deaths, to reduce cases, and to reduce the risk of emergence of even more dangerous variants. Transfer of mRNA technology is key. This can be scaled up faster, cheaper, and more reliably Also, it can be tweaked more readily for variants, and it's less susceptible to production problems. mRNA technology is our insurance policy against production failure and against vaccine escape mutants. We need to do much more to scale this up. This was created with US taxpayer money, and it needs to be shared widely globally. Next, please. Large-scale manufacturing is possible. We have to address finance, human capital, and the duration of stability of the vaccine. There's lots of ongoing improvements that can be made. This is not a new technology. This is a technology that has been under development for more than 2 decades, but this is the first time it's being widely used, and we need to optimize it as we move forward. We know already the mRNA vaccines are stunningly effective and remarkably safe. We need to get them out more widely. Next slide. There are lots of considerations about vaccine delivery and demand in terms of time, predictability, phasing. We have to protect those most likely to die first. We have to protect healthcare workers first. We have to have clear rollout strategies, and then we have to follow those strategies. Next slide. We also have to counter misinformation about vaccines, which spreads more rapidly than the virus itself. We find that it's best not to try to interact directly with those spreading misinformation. That just amplifies their voice and gets them to dig in deeper. But we need to increase the number of trusted, credible, consistent sources with accurate information, listening to concerns, acknowledging those concerns, presenting the facts about vaccine, that these vaccines are remarkably safe and remarkably effective, to give truthful and impactful stories, and to remain consistent in our messaging. Final slide. Health threats can either unite or divide the world. The choice is ours. Health has been a bridge for peace in smallpox eradication, childhood vaccination, leaded gasoline elimination, and more. Vaccine nationalism will backfire. Only global collaboration against the virus can lead to global recovery. A global commitment is needed to strengthen early warning, rapid response, effective prevention, the 7-1-7 approach. The world can save millions of lives and trillions of dollars. Tony Fauci has said never again. We should never, ever be unprepared for something as catastrophic as what we're going through now. It's literally now or never to make the world much better prepared. Thank you very much.
Tom, thank you. Thank you very much for that very comprehensive and insightful talk. We have about 240 participants on from all over the world. I'm going to ask folks, if you have some time, Tom, to put any questions in the Q&A box. But maybe I'll start with a question. I'd be interested in your thoughts on. Well, you alluded to the panic and neglect cycle, and obviously we want to try to avoid that with this terrible pandemic. I'd be interested in your thoughts on, what do you see coming out of, the COVID-19 pandemic that will really, make substantive and sustainable changes. I think an obvious one is the mRNA vaccine, which as you spoke about, is really a transformative technology for vaccines, and I think we'll see more of that. But in your mind, what are some of the other long-term sustainable benefits that will put us in a better position going forward as a consequence of this tragedy?
Well, I'm hopeful that this is a wake-up call for the world, that we'll see sustained funding in the US and sustained funding globally. In the US, there are proposals which we think are very important to exempt certain health defense operations from budget caps. So it doesn't become a budget game, each year having to fight to keep our defenses up. Just imagine if the Department of Defense had to go back and get our radar system refunded every year. But that's what public health has to do the equivalent of. So we need a new way of doing the budget in the US. Globally, I do think the 717 approach has a lot of potential to increase accountability. Think about 90-90-90 for HIV. It became a global rallying cry and a global way of focusing attention and accountability. We think 717 can do the same thing. Let me just mention, there were a couple of questions in the chat. This will be posted as a recording, I understand, by IVAC. Also, we'll adjust the slides, finalize them, and make those available for download. There was a question about protein subunit vaccines. These also show a lot of promise. We're just getting data on them now. Like the mRNA vaccines, they don't require a biological process, so production may be more reliable. They do require an adjuvant. There are concerns about adjuvants in some places, but I think the subunit vaccines we've seen out there are very impressive. In fact, the vast majority of the vaccines we've seen out there are really impressive. Some do a better job than others at preventing infection, but virtually all of them that have been studied do a very good job preventing severe disease and death. This is remarkable, and it's a reflection of the fact that our bodies do a pretty good job fighting COVID. And so the vaccine is able to build on that natural capability to create those kind of effective programs.
So Tom, I'll lead us through some of the questions that are coming through both the Q&A and through the chat. But one question was on how can we best combat misinformation and bad actors? Obviously, that's been a huge problem with this pandemic. It was recognized as a problem before the pandemic. Your thoughts on that, recognizing it's a very complex issue?
Yeah, I don't think there's one simple answer. I do think social media companies need to do better at stopping misinformation. I think the media needs to do better, but also we in public health need to do better. We need to be out there real time. We need to recognize that there's certain people we're not going to convince, don't try. But there's a large movable middle. There are people who have valid questions. People think, for example, oh, these mRNA vaccines will rush to market. Well, actually, they've been researched for 20 years, and they were approved rapidly because huge studies were done of these vaccines, more than 100,000 participants, the biggest vaccine studies ever. I think we have to address the valid concerns and find multiple messengers, whether it's doctors, actors, people who have a large social media following. There's a lot of volatility in the perceptions, and we in public health need to be able to move a lot quicker for that.
Great. Tom, you mentioned primary health care and universal health coverage as, two slogans that we have talked about for decades. You referred to Alma Ata and universal health care. And so one of the questions was, how do we encourage a stronger investment in primary health care, given that it hasn't been an interest of donors or even of governments? And I know it's also a big part of the Immunization Agenda 2030 is to to use vaccines and immunization programs to both promote primary health care and universal health coverage. But those are lofty goals, and obviously the challenge is really bringing those to fruition and implementing them.
We recently did a seminar on this with the Council on Foreign Relations, and we drew together Thailand and Costa Rica, two middle-income countries that have excellent primary healthcare systems, comparatively speaking. And what was striking is that they both use team-based care, and in both countries, primary healthcare has become really a politically salient cause. People recognize the value in their community. Politicians don't touch it in terms of cutting it because they know it's really important. Now, it took a long time for those countries to develop that. So I think all of our challenge globally is how do we really change the way public the public perception of primary healthcare is how can we identify countries, communities where there can be much more rapid progress. In the immunization world, we've been talking for many years about the healthcare platform for immunization, moving beyond campaigns to routine immunization. I never liked routine as a term, but life-saving immunization as part of core healthcare. So I think this is going to be not easy. We don't see donors doing a lot in the primary care space, but I think the answer is going to have to be beyond the technical. The answer is going to have to get to the political as well, making primary healthcare a political issue, not a partisan issue, because that's the kiss of death. Make it a political issue so that all politicians, and if you see many countries, the healthcare service, if you look at the United Kingdom, whether you're right wing or left wing, far right or far left, everyone is in favor of primary healthcare. That's the kind of society-wide consensus that's going to be extremely important to strengthening primary healthcare.
Right. And, somewhat related to that, it looks like there are a number of questions related to, global vaccine equity, obviously really highlighted by the inequities that you spoke about with the COVID-19 vaccine. But, and you talked about this somewhat, but maybe any further reflections on what we really need to do to address some of these barriers to global provision and distribution of vaccines in low and middle income countries. And I think, as you said, a big part of it is increasing the manufacturing capacity, but there's more than that, obviously.
Right. For COVID, really, vaccine manufacturing is crucial, but the broader issue of vaccine equity and vaccine access, let's first celebrate progress, because there's been a lot of progress with Gavi, the vaccine initiative, polio, we've been so close to eradication. The number of measles deaths has fallen dramatically in the past decades, with tens of millions of lives saved. So let's not lose sight of the progress, but in order to build on that, I think we do need stronger primary healthcare systems, and we need stronger information systems so that we're using data to improve performance. And that's crucially important. Also, making sure we have that political support. I sometimes use the acronym TOP, technical, operational, and political, TOP. You need them all. You need technical rigor, operational excellence, and political support. And for any public health program, you need that. You need them in different proportions for different programs. If you're going to take on the tobacco industry, you need a lot of political support. If you're going to take on vaccines, operational management is extremely important. There was a question in the Q&A about is 717 feasible in low and middle income countries? The answer is absolutely yes. In fact, there's been a lot of progress in Africa and elsewhere recently. The challenge is to make that progress for every outbreak in every community. And making a global target like that maybe makes it more likely to be able to be achieved.
Yeah. Oh, great. I just to pick up on that point, the World Health Organization recently announced that China eliminated malaria, and they had a 137 program, very, very kind of analogous concept but it just makes it very simple. It makes your goals very simple, and then you can monitor your progress.
If I could just say it, resolve to save lives, we have a basic approach that we summarize with the 3 S's: simplicity, speed, and scale. We find that public health programs, if they're kept simple, can move quickly and go to scale. Every additional layer of complexity makes it slower and less likely to scale.
Yeah, exactly. So, Dr. Frieden, your friend, Dr. Matusan Tosham, thank you for your talk. And he asked about, the Delta variant. He wants to know kind of how concerned are you about the Delta variant, both here in the United States and globally?
So Delta is concerning in that it's like a heat-seeking missile that will find the unvaccinated. And what we're seeing is quite striking in places including Israel and United Kingdom that have very high use of vaccines with very high efficacy of the vaccines, we're still seeing increases. In the US, we're seeing increases in the places with low vaccination rates, and I anticipate that we'll see increases, though less striking, in some of the areas that have more vaccines. Now, the bad news about Delta is that it's about 3 times as infectious as the original strain that was already pretty infectious. That means that the herd immunity threshold is going to have to be even higher. The good news about Delta is that our vaccines continue to work very well to prevent serious illness, hospitalization, and death from Delta. There is some mixed data about how well they prevent infection, but generally they prevent infection well. So Delta just tells us we need to do a better job getting vaccines out faster. However, Delta also tells us that this virus, SARS-CoV-2, has not necessarily yet dealt us its worst trick. That there may be future variants that are even more deadly, that evade vaccine-induced immunity. And that's one of the many reasons why it's in all of our best interests to reduce uncontrolled spread of COVID anywhere in the world.
Yeah, great. We've heard of the Delta Plus, and what we don't want is the Delta Plus Plus, and just getting worse. So one question, Dr. Frieden, is about the role of civil society in advocating for change at the international or national policy level and community health levels. And so just some of your thoughts on the role civil societies can play in making some of these changes that you've suggested.
Civil society is extremely important, and that can be non-governmental organizations, that can be businesses, that can be non-health organizations, the whole of society. And it's important for pressuring government to do the right thing. Our general model of progress in public health is strengthen the public sector, because public health ultimately is a public sector responsibility. Strengthen civil society to pressure, but also support the public sector to do a better job. That might be providing in-kind donations, advocacy, extending the reach of efforts, critical support or criticism, if there is criticism merited, and accurate information so that all of society knows what's really happening and whether we're achieving the goals we set for ourselves. So I think civil society involvement is extraordinarily important. If I can just give an example from the tobacco world, organizations around the world that have advocated for tobacco control through programs like the Bloomberg Initiative to reduce tobacco use have been pivotal in improving government policies. And those policies have already come into place that will save around 40 million lives from tobacco-caused diseases. So civil society is crucial, and I think we in the healthcare and public health field need to get better at engaging with civil society, whether that's media, social media, NGOs, businesses. It's interesting, if you look at COVID, this was so disruptive for so many companies. We would hope that they would become advocates for public health so that the world never, ever has to face something so disruptive again.
Thank you. Dr. Frieden, I'm jumping from topic to topic as I'm trying to synthesize all these things coming in, so I apologize about that. It's struggling to group them, but I'm going to come back to COVID-19 vaccines. And there was a question about parents being reluctant to vaccinate children, currently eligible children 12 years and older, and what role can schools play, or should they play, to promote vaccination? How do we address this problem of vaccine hesitancy among parents for their children?
It's understandable. I think first we have to empathize that parents are concerned. The vaccine is new. The term RNA scares people sometimes. And the fact is that kids don't often get severely ill from COVID. Some do, but they're much spared the severe illness of older people in general. But as the Delta variant spreads, and it's becoming the predominant strain all over the world, it's not sparing kids. We want our kids to be in school and learning. For that to happen, we'll need a layered approach. Kids under 12 can't get vaccinated. We need to continue to mask up in schools. We need to think about things like improving ventilation, having appropriate responses if there are cases and clusters in schools, protecting those who have underlying conditions and may be at particular risk, both staff and students. But speaking with parents through their pediatricians, through the people they trust, through influencers, because sure, no parent wants their kid to have any pain, not the pain of a prick of a vaccine, but also not the pain of illness that can be severe from COVID or post-COVID complications, and certainly not the pain of knowing, if you're a child, that you got disease and you spread it to a loved one, perhaps a grandparent, who died from it. You're going to have to live with that every day for the rest of your life. None of us want our kids to have to go through that kind of pain.
Right. Thank you. One of the participants you asked about the top, and particularly the political side of that, and acknowledged or recognized that in some countries, and they refer to low and middle income countries, but I don't think it's exclusively that. There's not, often the political will, and obviously you've, in your role as the director of the CDC, have interacted with politicians and the political world, and maybe some advice on how you try to engender that political will when it's weak or not there as a public health practitioner.
Well, there's no magic answer to that, and it's going to be different in different places and in different times. I will share with you a brilliant answer to that question given to me by now deceased, but a wonderful man, Senator Inouye. He was a World War II hero, injured in World War II. He was a senator, very effective senator. And when I became CDC director, he was extraordinarily powerful as the chair of the Appropriations Committee in the Senate. And I asked him, Senator, how can we have more resources for global health? And he said to me, don't tell us the good things that will happen if we give you the money. Tell us the bad things that will happen to us if we don't give you the money. And I think it's probably pretty accurate information, but also individuals can make a big difference. Civil society, community, affected communities can advocate for themselves, can advocate for public health, can make a real difference. I'll just tell you a story. It goes back to my time as TB control director when we met back in New York City.
Yes.
There was a change in mayoral administration, and there was a concern that a commitment to renovate the TB clinics would not be followed through on. And so the New York Coalition to Eliminate Tuberculosis wrote a letter to the mayor asking, would this new administration follow through on its commitment to renovate the clinics? That letter went, typewritten letter, went from the mayor to the deputy mayor, from the deputy mayor to the commissioner, from the commissioner to the deputy commissioner, from the deputy commissioner to me. And I didn't know what to say for the mayor, so I wrote kind of a wishy-washy letter, and it went back up through that chain, got to the deputy mayor, who wrote on it, no, we're going to renovate the clinics. And that was the policy decision that came back, and we wrote the letter, committed to renovate the clinics under the new administration. Now, the interesting thing is, the New York Coalition to Eliminate Tuberculosis at that point was one man, a man named Charles Ehlers, who had recovered from tuberculosis and was, as a single person, an advocate. And it shows that an individual person, and even more an organized group, can make an enormous difference in advocating for good public services.
That's a great story, and that maybe this is a good place to end. I think we've covered most of the topics. If I have left off an important topic, but I think that last message, Dr. Frieden, to our participants, that each individual can play an enormous role We may not feel that we can, but as individual advocates, as members of civil societies, and then as voters and influencing our politicians, we can all together, as President Biden said, all together. If we're together, we can do anything, and if we're together as a global community, we can address these public health problems. I don't know if you see it. Yeah.
No, I think we've covered a lot of ground. I really appreciate the excellent questions, and appreciate the opportunity to speak with you, and thank everyone here for your advocacy for health, for vaccination, for progress, and for our ability to work together as a world united against a common enemy, which is the bad parts of the microbial world. So thank you very much. It's been a pleasure to speak with you all.
Great. Thank you. We have a lot to think about, and we're very grateful to you.